Good morning. Welcome all of our audience from the United States and around the world. My name is Robert Lookstein, and we're broadcasting from Mount Sinai Hospital in New York City. We have a fantastic case we're going to share with you this morning. I hope it's educational. It's one of the, I would say, novel procedures that we offer for symptomatic patients here in the Northeast and Mid-Atlantic states. I'm proud to introduce our guest moderator this morning, a very, very close friend and colleague and partner, Dr. Saher Sabri. Saher, good morning. Thank you for joining
Hello.
us. By way of introduction, Saher is the Chief of Vascular and Interventional Radiology at Medstar in the Washington, D.C. Metropolitan area. Saher is also the Society of Interventional Radiology Secretary, soon to be the Society of Interventional Radiology President-elect. And Saher is an expert in the case that we're about to share with you this morning. Saher, thank you so much for joining us this morning, and I'm looking forward to a great conversation. Hopefully, we'll all learn something.
Thanks for having me. Always fun to be with you guys. Amazing work as always.
Thank you. I think we're going to go to the lab. We have a fantastic case. Rahul Patel, one of our esteemed faculty, along with Vivian Bishay, have set up a really fascinating case, and we're looking forward to it. So, Rahul and Vivian, the virtual microphone is yours.
Thanks, Rob. So I just want to introduce everyone we have in the room. Obviously, I want to thank our nurses and techs and our wonderful anesthesia service for helping us do these live cases. We can't do it without them. So to my left, I don't know if you guys can see her, is Dr. Bishay, one of my co-attendings, and then Dr. Watchmaker, who is one of our soon-to-be graduating IR/DR fellows, who's actually going to continue on and do our novel sort of neuro-IR pathway as well. But we have an interesting case today, so hopefully it's good because I don't think everyone kind of does this stuff. So Jenny, if you want to take it away.
Sure, thanks so much, Dr. Patel. So we'll be presenting a case on portomesenteric reconstruction. So this is a male in his 50s who originally immigrated from East Africa 20 years ago. He presented to our emergency room 1 week prior with severe abdominal pain. His mass medical history is notable for labs that showed thrombocytopenia and neutropenia, for which he underwent a CT scan that was notable for findings of portal hypertension, non-inclusive portal vein thrombus, for which he was started on Eliquis, did not have ascites at the time. His workup revealed active schistosomiasis infection. He's status post-successful treatment, and he has been undergoing esophageal variceal surveillance, and he had his esophageal varices banded 2 years ago. He has no history of GI bleeding, encephalopathy, or jaundice. When he presented last week to our emergency room, the CT scan was notable for new ascites, very large esophageal varices, and progression of his portomesenteric vein thrombosis. Here we have the cross-sectional imaging. On the left, we have coronal images from his index CT scan 3 years ago. You can see the non-inclusive portal vein thrombus extending into the SMV, varices, but a patent main portal vein. If you look on the right panels, that's his current CT scan. We see new ascites, progression of his varices, very large esophageal varices, and occlusive thrombus within the portal vein, as pointed out by the arrows in that slide. So our plan for today, he's a middle-aged man with a history of hepatic cystomiasis causing portal hypertension. He has very enlarged esophageal varices with progression of his portal hypertension, likely acute on chronic portomesenteric vein thrombosis. So we plan to reconstruct his portal venous system with direct portal access, perform TIPS, and possibly embolize some varices today.
Thanks, Jenny. Yeah, so he got scoped again by our endoscopy service here, GI service here, and the varices that to them looked very scary. They were large, no stigmata of bleeding, but their concern was that he's going to have to obviously restart his anticoagulation, and given the varices, they were concerned for bleeding and sort of compliance with the anticoagulation. So they asked us if we could potentially decompress him. So Saher, I guess I would throw it over to you. So how would you guys approach this case or patient?
Yeah, it's a fascinating case. With such an occlusion and the varices, I think what you described is a transplenic or transhepatic access reconstruction and a TIPS placement and embolization. The main differentiating thing would be if this is a cirrhotic or non-cirrhotic portal hypertension. Are they a candidate for liver transplant or not? I think that's a huge fork in the road, and you have to kind of decide. And if they have intrinsic liver disease and they can potentially eventually be a transplant candidate, then we make every effort to preserve the main portal vein. But if they're non-cirrhotic portal hypertension and thrombosis, then we're more liberal with extending the stents into splenic usually rather than SMV, but either or. And with such varices, probably into the splenic. So that is the main thing I need to go into the case to see what the endpoint would be.
Yeah, exactly. So, you bring up a good point, about not extending the stents too far, especially if they're a transplant candidate. You can extend them into the main portal vein, but not too close to the bifurcation of the SMV and the splenic vein. The transplant surgeons start to get angry because it changes their surgical approach. They may have to mobilize the pancreas to get to that spot. So I'm going to show you what we've done so far. Just sort of our setup right now. We have right IJ access. We have our tip sheath in the right IJ right now in the right hepatic vein. We have an arterial line in the right groin, sort of for taking pictures afterwards to check for bleeding, and also for monitoring during the case. And then we got transsplenic access under ultrasound. So there, we just under ultrasound guidance, we got transsplenic access. We sort of pick a peripheral splenic vein in the lower pole, sort of easier. And then we were able to, if you can go to the next one, so then we just wired. Luckily, our nitrix wire was able to go across. If you can go to the next series.
Rahul, maybe you could talk a little bit about
Yeah,
how you gain access to the splenic vein, because I think a lot of people, that are
yeah,
watching or going to be referencing this, are not familiar with splenic vein access. So if you could just spend a moment or two talking about how you set up that kind of access, and then Saher,
yeah.
I know that you do this also. Maybe you all could sort of chime in about whether you have a different strategy or whether there's any sort of technical tips that you could offer for people listening in.
Sure. Yeah. So again, I try to take a lower pole access just because it's easier to get to. I don't have to fight the ribs. Sometimes, obviously, if the spleen's not super big, you can't always do that. I try to pick a peripheral splenic vein. I usually also look at the CAT scan in patients that have very extensive portomesenteric thrombosis that extends out into the splenic vein. I'll try to pick a splenic vein that looks at least to be in continuity or near continuity with the main splenic vein, because sometimes you can get stuck in a
Mhm.
splenic radical that's not really attached to the main splenic vein. And again, you don't want to stick central. You don't want to stick the extra. I mean, you can. My preference is not to try to stick the extra splenic vein, so like into the splenic hilum, and that's sort of how I approach it. Again, I try to also stick in line, so I don't want to end up perpendicular to the vein and then have sort of like a weird turn or kink in the splenic axis. So try to keep everything straight. Not always possible, but that's sort of my goal there.
Yeah,
And
I
this
mean,
patient has
all
marked splenomegaly, so it
Yeah.
gives you more options. Obviously, in a patient who has a normal size spleen, this may not be the approach that you can take.
I mean, all great points. I mean, and the only thing I want to add is to really do it with ultrasound and not just rely on the
Yeah.
wire, just going forward, because you can dissect easily through the splenic parenchyma. So as you advance your wire, you need to make sure. So like the idea through the needle, do a quick puff or run just to kind of map where it's going to go. So then you make sure your wire follows that path. I usually try to kind of do fluorofade or smart mass to just kind of watch my wire go through that, because you can easily be
Yeah.
fooled as the wire goes and it goes straight and you think you got it, and then you can dissect through the splenic parenchyma easily. So, and you can end up in the splenic artery, which has happened many times. It just goes easily, and it's
Yes.
easily from the parenchyma into a small branch. And then, so as soon as you get in, before you upsize through your micropuncture, do another run. And, it happened, I would say 1 out of 5, 1 out of 10 times, you'll end up in the artery. And if that's the case, then you just come out, embolize that track, and then start over again.
Rahul likes to
Excellent
say that you
technical
always get
point.
blood back from the spleen.
Yeah. So yeah.
So again, you don't want to be fooled. You want to confirm that you're in the vein, 'cause
Yeah.
you'll
Yeah.
always
Exactly.
see blood when you put the needle in the spleen.
Yeah, I was going to say, why don't you walk us through the splenoportogram and show us
Yeah.
where you are now, right now.
Yeah, so luckily, when we put the nitrix wire in, it kind of just sailed across. We sort of knew we were in the splenic vein. It kind of got locked up where we would expect it to get blocked, which is sort of at the portal confluence there, the splenic portal confluence. And so once you put the AccuStick in, or is it an FSET? We got an FSET?
This is an FSET.
Yeah, an FSET. So once you put the FSET in, we did a quick portogram, and you can see here basically sort of a normal splenic vein, a big coronary vein, and then once you can see that big sort of cavernoma going up towards the liver, which he'd had before, and it's just a little bit more robust. And then you can see sort of what looks like the nub of where the main portal vein should be. So just medial to that cavernoma that's going up to the right upper quadrant. And so then if you can go to the next series. So again, through the AccuStick, you can put a 4 French diagnostic catheter. Again, because we're going to I figured we're going to end up gunsighting this patient to connect the dots. We use a 4 French BER from Cordis, which is actually 038, and the 10 millimeter loop snare will actually fit through it, so I don't have to put the wire out to where I want to go and then exchange. So, ultimately just trying to find a right anterior portal vein. Again, we also want to make sure we're in the right hepatic vein to make sure that the orientation is correct. So you want to find a portal vein that's anterior to the hepatic vein and kind of go that way. And then ultimately you want to make sure that the angles, once you pick your spot, you kind of want to make sure the angles make sense. So you don't have a TIPS that has a very sharp right angle or is upside, what I mean by upside down or backwards, where the orientation looks like it's going towards the back. Again, you can kind of work through some of this stuff, but if you end up super lateral in the liver or in like a weird angle, you can get a TIPS that you can connect, but you can't get the stents to go, and you end up with like a weird kink. So we try to make, when we do a gunsight, we try to make the angles look like it would for a normal tip. So it's usually a little bit of an LAO and sort of usually a steep cranial caudal view to get it to go. If you can go to the next series, I don't know if there's another one. So here it's just an injection. Once we're able to recanalize the portal vein, we're in sort of in the right anterior portal vein here. There's a little injection there. We're sort of like in a radical, probably a little bit more distal than we would sort of end up. This is a little bit of an angled view. This is like 22 RAO, so it's a little bit more central than it looks like on this image. If we can go to the next series.
So you just worked your way to that point based on sort of the configuration and where you expect
Yeah,
to be,
exactly.
right?
Yeah, so exactly. So we sort of worked our way to that spot. And then so now what we have here is just showing you. So what the angle here is a LAO2, because it's kind of where it gets it to line up. We're in a very, very steep cranial caudal. We're about 43 degrees cranial caudal. And then so then we have a 20 millimeter loop snare in the right hepatic vein and a 10 millimeter snare through the Berenstein catheter here. And so that's sort of how we're going to set up to start the gun sight to connect the dots here. You know, we used to try to do a couple of throws, but some of these patients, the anatomy is sort of messed up and they're going to end up having me on AC. So I can do this sort of quick one shot through the liver, and it just sort of makes it go faster for me. I don't know about Saher, how you guys approach these. Do you guys try to stick a couple times?
Yeah, I mean, these are all great points. I mean, you can, get moving if you want to with your gun sight because there's a lot of work to do, but we can chat as you go. But I would say that in a few points, gun sight for me, that's our preference as well for such cases. I just try not to kind of waste too much time trying to do throws from the IJ when I have this set up. It's much easier to go. One thing is I usually take my ring off before doing that. I'm just kidding.
Rahul never does. This is a
my
classic sign.
I know, just to show that you have it.
It's an aura ring also, not to send out any advertisements for the biologic rings, but
yeah. This is brought to you by Aura. So
right.
the one thing is you made a lot of great points about, it was very tempting to see that huge cavernoma and it just looks like in line and people would follow it. Part of the issues of not going through that is if you end up stenting into it, you may end up with biliary obstruction and major issues. So you really need to go to that area you pointed out, that nubbin that shows where the portal vein is. You made it look easy, but that is the rate limiting step I found of the procedure, is to try to go from that area into it. And the second part is,
sorry.
go ahead, Vivian.
Oh, I wanted to just, sometimes if you do kind of like a delayed portogram, you can see the remnant a little bit. In this case, we just see the nub here, but it's, kind of a telltale sign for us where to start interrogating rather than going through the varix, like you said, or the
And I know you're
cavernoma.
now trying to puncture the snare in the portal vein first, and that's your main target. And I know they're overlapping each other, but your main focus is that first one. And once you're through it,
Yeah.
I don't know if you do that, but just try to close the snare to make sure you went through it so that you don't, before you keep going for the next one, just to confirm. The only thing I do differently is I usually upsize to 6 French from the splenic, and I think this is a great technique here to show that you're definitely through the first snare before proceeding to the next snare. I go with a 6 French, Ansel, and then I would do is I just put a bigger snare. I just want a bigger target, and most of the time we do fine with that. So it looks like you kind of got close to it.
Just see if you're through the.
Yep.
One
Yeah,
of the
we're through.
To go.
That's a great shot right there, that you're clearly documented that you're through both the portal vein snare and the hepatic vein snare, and it's literally the definition of the gun sight technique right there. So just a fantastic image demonstrating how this can be executed successfully.
Okay.
And what needle are you using here?
So again,
Yeah.
it's an 18 gauge NRAD, so it's 15 centimeters. I would say like 95% of the patients, that's actually an okay length. You can sometimes jam on the liver to get the rest. We used to do the 018, so the 21 gauge or the 20 gauge, and use an 018 system, and then it just added a lot of extra steps. in terms of trying to upsize to get back to an 035 wire. And so we kind of stopped doing that. We just sort of did 035. Whoop. All right.
Yeah, I still do the
Do you want
018
to inch back the?
Yeah.
needle. One of the issues with it is, as you said, two things. The needle is flimsier, and then you're going through the steps of sending an 018 wire, snaring it, then then reversing. Well, here you go to 035. The downside using a bigger needle, so if you're not as comfortable with the technique, I mean, you've been doing this for a long time, you published on it, so it's easier for you to do. But I think if
Yeah.
you're starting and you're not as comfortable, probably a smaller needle will be probably easier, but you made it look really easy here.
So yeah,
Rahul
so
and Vivian, you just externalized I believe, an 035 hydrophilic wire. So
Yep,
just walk
glide wire
us
advantage,
through
yep.
the next steps so that we can sort of forecast what you're going to do. And then there's a couple of questions I'd love to ask Saher while you guys are switching everything out to be able to allow you to successfully reconstruct the shunt.
Yeah, so the next step is obviously, well, not obviously, but you shouldn't really try to snare the back end of the wire out, because you'll either one, it won't come out, or you'll just sort of rip through the liver, and then obviously that's not a good thing. So what we're going to do is we're going to put sort of a softer diagnostic catheter through. So we'll put an 035 4 French glide cath through.
It's 100.
It's 100 centimeters.
cm.
Yep.
And then, so what I will do is back out my needle a little bit, open the snare, the O.
You have wire.
And is this a stiff
Open the
glide
snare.
or some sort of a something
No,
like
so we actually
that?
used a glide wire advantage. Just so, yeah, we used to use.
Okay, I'm gonna go.
Is it not going through? I may not open the snare
Yeah,
enough.
loosen your snare
Yeah, we
from
have to
this
loosen
one.
up. Mm-hmm.
Yep, there you go. Push, push, push.
There
Yep,
we
there
go.
you go.
Right. So the
So
tip of the
she's pushed
catheter
through.
just crossed through the portal vein snare, allowing you to snare the actual catheter, which is a very important technical step in this procedure of reconstructing the gun site to allow you to have through and through access.
Right. So I don't know if you guys can elucidate that. So we used to use a exchange glide wire, stiff glide. The problem was when you're trying to pull the wire back out, because now to remove the 035 wire, sometimes what was happening was that it was shearing off the Teflon coating from the 035 wire. So the glide wire advantage obviously from the back doesn't have it. And so here actually the tendency was to pull it out of the body from the abdomen side. But what we're gonna actually do is we're gonna actually pull it out from the neck side. So she's gonna pull it.
So I'm going to just start slowly pulling it. We can again see that the catheter is through our
Give the
portal
control
side snare.
Yep, just keep going.
And the idea here is to take the wire out, so now you have the soft catheter that can be snared, and you have it really tight. You have a tight grip on it
And you've
from
got
this.
So we just put it back through. Yeah, and then what
So
I'll
the
do is I'll
access
just gel
wire's
foam.
been removed. The access wire's been removed, and now you've snared the catheter from the jugular side, which allows you to have through body floss eventually once the soft catheter has been externalized.
And so the other thing is what I've found or
You're
seen.
pretty cinched on it.
I'm cinched on it. Is that the glide wire, because it's so stretchy, it will sometimes it'll stretch and become like a bit of an accordion or a Chinese finger trap. So what I'll do is actually I'll just to give the back of the glide wire a little bit more body, is I'm going to put it into the catheter, but not all the way through, just to give it a little bit of extra body. And so interestingly, again, just sort of trial and error, is now I'm just going to pull on this. Oop, hopefully.
I think you're not fully cinched, or are you?
I think I am.
Maybe it's on FOSS and we're just not seeing
Yeah.
the little tip.
Make sure. Don't want to do this twice.
No.
Okay. You have to feed it a little bit too.
Yep.
There we go. Even though it's a 4 French glide cath, it should fit through, doubled over through the Aki stick. Yep, there we go. So now I have, unfortunately you guys can't really see it, but
we have the glide catheter floss,
I have the glide
basically.
catheter flossed out the other side. It's got a weird angle here, but I think some of that's going to straighten out once we get rid of some of the tension.
I'm going to take the wire.
No, push the wire out.
Oh, more. Oh, sorry.
Yeah.
So, Rahul, now that you have
sorry.
a glide wire floss through the patient, are you planning on working over the glide wire, or are you going to exchange it for a different workhorse wire?
So, it's a glide wire advantage. So now that I have it snared and I have a rail, I can just work over this. I don't have to keep doing another exchange. So the other thing is just to make sure it doesn't bleed. I put a 2E on the back, and then I can bring this out a little bit more just so I get on the green part of the, just push more wire. Okay. So now I
Yeah, I
have
mean,
the
I
wire
mean,
sort of
take the
clamped
catheter.
here. Yep. Yeah. And now she can pull the catheter out. It's snared, so you can just, yeah.
yeah, everything straightens
So
out
now,
now.
yeah, everything straightens out. So now it looks like a normal TIPS, right? What we would expect a normal TIPS to look like. Obviously, we don't have the track, so we're gonna go with the balloon next.
So Saher, let
And
me
so
pivot over to you because we get asked this question a lot by our colleagues in our professional network up here in the New York City metropolitan area. These patients with chronic portal vein thrombosis, inevitably there's an opportunity to intervene on them or to try and be a little bit more preemptive when they start to present with acute portal vein thrombosis. And I was just curious about how your group at Medstar manages the acute presentation of portal vein thrombosis. There's, I think, different schools of thought. One is that
Ready?
if the patient can be
Gently
managed
pull this wire.
medically, let it sort of, chronically occlude if the patient's symptoms are minimized, and then you can always
wanna
manage them if they
just
really
lean more up in the front?
become, truly
Take this
symptomatic
back a
and
little bit so
refractory
you can
at
No,
a
just
later
because this is
date
all
doing a
occluded, right?
procedure like this. There's another school of thought that says no, we should be more aggressive and perhaps do a portal vein thrombectomy in the acute setting and subject them to an invasive procedure to minimize the incidence of these downstream effects. I'm just curious how your group in the DC area manages these patients. I'm well aware you're a large referral center for this, and you obviously have extensive experience. I'm just curious if you can share your own insights.
I think we
Yeah, I
see
think that's a
the
great question, and it's always up
copy
for
of the
debate.
SMV.
Again, I just
Huh?
divide them into cirrhotic
Thought
and
that was the origin
non-cirrhotic,
of the SMV,
and
but I
I
don't
think it's
know.
like right there.
any cirrhotic patient that has, is a transplant candidate, then we're more aggressive in
Do a run.
opening them. So I think that is the main differentiating factor. So when they come,
We
we
do a
start
run.
with anticoagulation for sure. And then during this acute subacute phase, we have a
Yeah,
discussion
there it is.
about the
It's right
transplant
here.
candidacy.
Mhm.
And if we feel that they are a good, this is a really good picture. Sorry to interrupt here, but and this
Yeah.
shows that where the cavernoma is and
So
where the main portal vein should be. So this is a great picture. So go back to your question. If we think they're going to be a transplant
dilate the
candidate,
Marker
then we
pig.
are more
tips and
aggressive
then try to
in
balloon the
opening their main
SMV.
And the
portal
portal, the
vein.
main portal.
If
Yeah.
they are not a transplant
Marker pig.
candidate, then anticoagulation is sufficient, given that they do not have active bleeding at the time. We've
I think a
seen some
step is
patients who
necessary.
come
It's like
with
always the
I'll
long
do it
term.
just to show it.
from the beginning. That's a becomes an easier answer. You go into TIPS thrombectomy. But if they have no portal hypertension stigmata happening, and just some ascites that is managed fine, then anticoagulation is a recommendation for these patients. For non-cirrhotic portal vein thrombosis, becomes a little bit of a more nebulous because we're not talking about transplant for these patients. Again, anticoagulation is the mainstay, but if they present with any variceal bleeding
That's
or
good, right?
significant ascites,
I think
that's when we do them.
we
So I don't think it's a trigger, say everybody needs a thrombectomy, because a lot of these patients
gonna
do
floor.
very well. There's some data shows up to
So you
2/3 get
see,
recanalized with anticoagulation only. So that's my algorithm
and then
usually. The ones who are transplant
Kind of entered
candidates
here,
and the
right?
one that have
Roughly.
severe portal
yeah, but
hypertension gets
where
a
do we want to
procedure.
extend it down
Everybody else
to?
gets
Well,
washed
I was
and
gonna
see
try to
how they
balloon the
do.
shit out of this and then see how much I
Yeah.
can extend, right? So yeah, so Vivian, those are all very great points. So, yeah, the non-cirrhotics are always tricky. You don't have to keep floor, right?
10. It's a 10.
Yeah, the non-cirrhotics are always tricky. Also, the extent of the occlusion will sort of drive that as well. So, we have patients that sort of have deep portal mesenteric occlusion. The SMV is totally shot, even though they're cirrhotic. They're not really going to be an isolated liver transplant, and so luckily they do
Watch me.
multivisceral transplants
We
here.
have an
But
8x2.
obviously, they would much rather us try to shunt
Eight
them
by
one way
two.
or another than having to do a multivisceral, because the morbidity and mortality of that is obviously much greater. And then obviously the non-cirrhotics, some of them are JAK2, a lot of them are JAK2 mutations, so that also ends up being tricky in how you manage that around transplant. You can see the run here we did, if you just tap Flora real quick. We're doing the measurements, so we're debating sort of how far to do the tips. I think what we're going to do is sort of land the tips as if we had an open portal vein and then try and see if we can actually just balloon the main portal vein to like 10 or 12 and see if we can get inflow that way without having to extend the tips all the way to the portal confluence. If we have to stent towards that area, we can, but my preference would be try to not to stent all that way.
Yeah, I agree. I mean, most of the time I end up going with an 8. You can measure, then go with the longest you have.
Yeah,
You know,
exactly. That's what Vivian.
We just said the
Vivian was
same
just
thing.
giving me crap because she's like, "Why are you measuring? We're always going to go with an. You know,
like,
you're going with an 8."
yeah, because it's
Yeah.
usually longer. So these tend to end up being longer, and
Yeah.
generally speaking, you can extend a little bit more into the main portal vein because it was occluded anyway. So, and I
Yeah.
think your strategies is, I think I agree with it. It's very well thought through, which is to angioplasty the main portal vein and see how much you can get away with it. If you can, preserve at least 2 centimeters of the main portal vein, I think that'll be much better.
Exactly.
But
Yeah.
again, if this patient is non-cirrhotic and a liver transplant is not in the works and your flow is really
Yeah.
poor afterwards, then you're going to have to
Yeah.
extend. But I think you can get a good
Yeah.
result here with just angioplasty.
And the other thing with around transplants, it's always a bit tricky. Some of these, especially the non-cirrhotic patients, they tend to be much younger. I don't necessarily want to jail them out of the option of a transplant, even though they're not necessarily a transplant candidate. So I try my best to stay out of. I don't want someone to come back and blame Dr. Patel for not allowing me to get a transplant. So I try to stay
Yes.
out of it if I can.
I mean, that
Yeah.
predicament now, a patient who said, yes, not transplant candidate, non-cirrhotic,
I don't
and
know if you're
then,
going to be able to.
just
You
We
may
don't
have
need
to
to
land
be
it
that
back.
far in, but
Yeah.
extending it further. And
maybe
now they're like, yeah, we're considering it for transplants. Like,
that.
I thought it was
What
non-cirrhotic.
do you think?
Just to recap, you all are placing a 10 centimeter long
Little bit.
implant that has 8 centimeters of PTFE and 2 centimeters of a bare
Hold on
metal
1 second.
scaffold. Is that correct?
Correct. So it's a 10-8 to Viator.
Okay.
And then Vivian just pulled the string there. Cool. I think we're going to end up having to extend more on the top, but that's okay. Can I get a
Yeah.
10 millimeter balloon, please?
Can you speak a little bit more about the top, when patients are going for
Yeah.
transplant versus not? I mean, what's your goal? I mean, this is always, debatable, and people will try to extend
Yeah.
too much and end up losing a stent into the heart and all this stuff. So you try to do it right the
Yeah.
first time around. So what is your goal,
Yeah.
especially patients who could be considered for transplant?
Yeah, so we kind of want into the hepatic IVC junction, although it's also a very nebulous spot. The other way I look at it is obviously the top of the stent didn't flare open to 10, and it should. So we're clearly a little bit short, or at least in a relatively small hepatic vein there. So we're going to end up having to extend it. Obviously, if it's floating a little bit into the right atrium, the surgeons get mad. The transplants can become more difficult. But I just want to show. Yeah, you can see
Yeah,
we're
we're short.
short.
I
But
think to
they
do
can
as an
sometimes. They
RAO,
said.
yeah, an RAO
Yeah,
sometimes can,
exactly.
can show this very well, just from a demonstration purposes, to show the
Yeah.
exact relationship
Yeah.
of the hepatic vein and the IVC. If you really want to pin it
Yeah.
exactly, it'll be good. Especially if you
Yeah.
have a question, it's not exactly so. An RAO
You go all the way to
25
the
or
front.
30 give you good answers of exactly where
Just
the
balloon all
junction
this.
is.
It's sliding right.
Um,
Yeah. Yep. Go ahead. Hit it. So we're gonna balloon.
um,
Normally for tips we wouldn't balloon so far forward, but we're just gonna balloon sort of the whole spot. Really not so far, but that's okay. Just go take it to 12. So we're just gonna balloon everything to
And
10 here.
obviously, this is not a typical
Take it down.
patient, right? We have a patient with,
Right there.
a portal
Up.
portal cavernoma. They've got a new onset ascites and extensive gastroesophageal varices. So, how aggressively are you post-dilating the shunt? 6, 8, 10. What did you decide to put in here?
So we're gonna go straight to 10. He has no real reason. Like his MELD is actually really low. If we're gonna say has some degree of chronic liver disease from his schistosomiasis. Um, but we're gonna take it to 10 just to get as much outflow as we need. It sounds a little mean, but if he does get encephalopathic or he doesn't tolerate it, we can always narrow it. I just don't want this to go down afterwards because that's actually a harder problem to deal with. Once you get into that cycle of thrombosis, it it doesn't always resolve itself, and it can be a bit tricky. So I'd rather just take it like 12, 14. We're gonna have to really
Yeah,
pop
get
it.
rid of that.
Yeah.
14.
Saher,
So
what are
yeah.
you doing in this circumstance? I know that you see these cases as well. Would you dilate
Yeah,
this to 10 and say you'll deal with the incidence of potential side effects on the back end, or would you take a slightly more conservative approach?
yeah.
Good
For this
control of the
particular
wire on that
case,
side.
on
Yeah.
these portal vein thrombosis cases, I usually go to 10 because you need the maximum, outflow as you can. And plus also almost all of them have either large shunts or big
Okay.
varices that you're embolizing. So you're replacing a large
And it's
uncontrollable
already.
shunt with a more, a smaller, a 10 millimeter shunt. So
So you want to extend the top?
Little.
end up in a better
Landed it a
setup
little low.
anyway.
It's okay. We're good.
So
Yeah.
that's
So
I would go with that. In any other setting, I would start with an 8 or even lower. Looks like the stent dropped a little bit into the main portal.
it did, but I think there's still enough room that if they had to do a transplant, they can. It's not obviously sitting on the bifurcation. So, Saber, always this question, and I don't know the answer. When you guys extend the stent on the that's a smart mask on the top, what do you guys usually extend it with? Do you do another Viator? Do you just use like a bare metal stent, a VBX?
I do a dedicated tip stent. I think it's just for various reasons. I mean, we've seen enough. I mean, you go to enough of these M&Ms and all the stuff and the complications. Seems to be that is this always comes up. A stent that is placed is too short or not the same type of stent that you
Yeah.
place, and there's a migration. The issues that could happen with a stent that could migrate is way more than trying to get another stent that matches the stent that you have. So for me, because it has the bare metal, has more coverage, more overlap. I usually use a 5 or a 4. Basically, the 4 covered, I mean, total length of 6 or total length of 7. The
Yeah.
new one, that'd be my extension. That gives me plenty of overlap. So I basically put the dilator, put the sheath back in or over the balloon, and then extend with another Viator in this case, because that's a stent available to us. And as the newer stents comes
Yeah.
in, we'll do for that. So that's
Deal.
my approach. Maybe it's an overkill, but I feel much safer that same type of stent, plenty of overlap, and I have not, knock on wood, have not had issues with migration. I've seen it with a balloon expandable stent because the way it sits and all that, it could,
Yeah.
squirt backwards. Bare metal stent's probably safe, but then I see that come back with instant restenosis at that one particular spot, and you kick yourself right into use a covered. So although it's not
Yeah.
as needed, for
Keep it down.
those reasons, I'm sticking with the Viator.
Yeah, no. So we've gone back and forth. I've done VBXs. I tend to take the 11 VBX so I can like really slam it in. But I'm always worried that like when you're going back through the VBX that it's going to collapse down into the IVC. It's going to sort of flop down into the IVC. We've done bare metal stents as well. So we usually obviously want to oversize. So I'll put like a 12 or 14 bare metal stent, and the tendency is just to put a short like 40. I'll actually put a 60 and have a lot of it sitting in the tips here. So here we'll actually, since we have you here, we'll put another Viator. Can we get
I'm
whatever the
not,
shortest Viator is we have?
have, I have no conflict of interest, just to be clear. With
Yeah. Just leave it on the wire for a second. Let's. So you
I've,
said RPO, right?
I just have for the person of complete inclusion. We've enrolled in the new trial, the ARCH trial, which is involves
Yeah.
a newer
Like right here.
newer stent
Yeah.
from BD, and it
Yeah.
has a
So we hit it right.
larger size matrix that has up to 10
specialist.
centimeter covered length, and diameter is all the way up down to 6 millimeter.
Do a run.
The controlled expansion. So I think I mean that kind of gives you a little
Yeah.
more options
view.
in terms of this looks really nice. Just a little bit of extension.
Yeah.
So it gives you
Sahar,
more
do you
sizes,
know what
can
the
do it.
status is of that trial, and when anybody who's watching this could anticipate that they would have access to that technology off of a protocol?
Yeah, so the enrollment is complete. Dr. Ziv Haskell is a national PI. The enrollment has been complete for a few months now, so we expect it to be presented soon. I don't know exactly what the venue or what the paper is, but I know the enrollment has complete for a few months now. So hopefully it should be soon, and then it goes through all the regulatory part with the FDA and all that stuff to get approved on the market. But I think it's good to have options.
Kinda want the image up.
I think the Gore Viator is an excellent stent. To have another stent, we'll see what the data shows, and if it's comparable or not, and to see if we have
Yeah.
another access to another stent that has a little bit more, size matrix. It some of the other features, you don't need the sheath to be in. It basically you do it like any other cell, bare metal stent. You just use a roller, so
Right
you don't
here.
need to put the sheath down and
That's pretty good.
unsheath part. So
There,
it's a
like across the.
more traditional deployment. So few features that I think will be good to have.
You like it?
Yeah, I think so. You want to unsheath it the rest of the way? Yeah. So yeah, we extended it about a centimeter or so up. We can kind of see.
Yeah.
I don't know which image you're seeing, but you can kind of see the road mapped smart mast image
Yes, we see the
and
small
then here
max
we'll
in
just
it, and you see that it's going back into the IVC
yeah,
right there.
good.
Yeah, it looks like you gained another probably a couple of centimeter and
Centimeter
a half
two.
or so. Yeah.
Yeah. So we can pull this out. The one good thing also is because we have a rail, I don't have to worry about pinning the wire and stuff. We'll
Yes,
just take the
Get
10
exactly.
that.
back and just balloon. Yeah.
All right, what do we want to
Yeah,
do the
one
rest
thing,
of the
as I
morning
said,
with?
I don't know
Do
if
you
you
want to
don't
get
mind
down
at
into
some
the
point
I can
do
do
SMV?
that,
a
right?
like an aerial run just to see the kind of relationship of the relationship of the stent to the IVC and the atrium. Sometimes it can give you
Yeah.
just from a
Oh, that's
demonstration
great.
purposes, but
Yeah, of
you've done
course.
this enough that you kind of good sense of where to land these.
Yeah.
Go.
You want to go forward then? Just because we're going to do the whole segment, right? You got right there. Yep.
Let me hit that.
And what size
Excuse me,
balloon is that?
It's still a
Still
10.
10.
10, just sort
Okay.
of slam it all in. We'll over dilate the 10 just to get it back in, sort of get the whole thing sort of engaged, the stent
And then we'll
column's
just get
engaged.
the front portion of it.
You want to do the top? Or yeah, okay.
Yeah, and hit the overlap. That's nice. Yeah, and you see,
Yeah.
I mean, again, the nice thing is that it overlaps well. You know,
Yeah.
then you don't worry about
Okay.
any issues with migration. But
So, are you all going to do a portal vein run now?
Yep. So that's, again, we're going
So,
to pull this back a little bit. You can take that balloon out. And since we still have the splenic access, I can just do it right through the splenic access here. You want to hit a run? This is AP.
ready?
That looks really nice.
yeah,
So,
Yeah. So the
couple
cavernoma
of
is not filling.
questions. Couple of questions. One is embolized varices, yes or no? Second question is visceral angiogram to document that you've got, direct outflow from the splanchnic circulation, yes, no. What are you all thinking of there currently?
So yeah, we'll do an
And or
SMA.
go down to SMV.
Yeah, we're gonna go
balloon a
down.
little bit, and then
We're gonna
do a
go
run
down.
from the.
Yeah, exactly. We're gonna go down into the SMV. So we're gonna put the sheath down into the tips, and then try to go down into the SMV just to show exactly its orientation relative to everything, as well. Yeah, so you can take the
be
dilator
good to
out.
get a pressure measurement at this point to see how things are at. Again, depending
Yeah,
on this patient. For patients who are non-cirrhotic,
go parallel.
Can I get
you
a
try to bring the gradient.
Benson,
You
I
don't
guess?
stick with the 5 to 10 gradient. You want it to be as low as possible for these patients with the JAK2 mutation and such that thrombose. So this guy is in between. I mean, he probably has some intrinsic liver disease, so he'll probably be a little
Yeah,
more on the conservative side. But that probably could help guide,
Yeah, there it is.
yeah.
generally speaking, what the embolization is going to be.
Actually, you're gonna need a
If
glide
it's
wire.
too
He's got.
low, then I think to answer your question, Rob, it's probably good to embolize so that lower risk
So let
of
me get that. I'll
encephalopathy in
just.
general. You take care of that shunt. But also if the patient did have a lot of, high stigmata or recent bleeding, I think it's reasonable to embolize. So I think I'll be more aggressive in the embolization.
I need
If
a
this was just for
Oh, there you go.
ascites and they never had
very. But I
any
think there's
bleeding
going to
or
be a
high
little
risk
like.
stigmata and we just see the varices and they don't have encephalopathy, probably would leave it alone.
Let's turn this.
And I think that's very good insight, and I agree that a little bit more of an aggressive stance or a proactive stance in the setting of concerning varices is probably warranted, especially when you have portal vein access and coronary vein access. I'm going to just
Balloon it a little
throw
bit
it
at that
out there,
confluence.
Yeah.
given that you have direct
You do it, right?
access now
Okay.
into the portosplenic confluence, what would be your preferred embolic agent, and how do you tackle variceal embolization
Do you want to do the
at your
varices first?
center?
Yeah, I mean, I think now you have a lot of options. I mean, I think this looks great. I mean, you're
Yeah.
again just slightly on the lower side on it, but I think the
Yeah.
confluence is open, so that's really good. And yeah, sometimes you can do runs through both to kind of show the flow and such. But this looks really good. Now, for that varix, yeah, I think it's probably good to get in it and what to treat with. If it's just a straight up esophageal
Let's
varices,
see where it is
I mean,
first.
just and depending how big it is, you can just coil. A lot of times I put some STS and Lapidol and then coil. If it's a shunt, if it's a gastrorenal
You
want the-
shunt, then I'm definitely
You know
doing
where?
doing a sclerosant. Basically, just doing the cetridocol with lapidol mix. You can add some gel foam to it as well. So that's mostly it. With glue, works very well too. You know, kind of 1 to 3, 1 to 4 works really well for these. So that's another good option. Try to use some of the newer agents. Used Obsidio from Boston as an option. I feel in these very large capacious systems, it's you're gonna need a lot to get there. So I don't know if it's the best option for
You back it up a little
varices.
bit.
It's very expensive for that, and the varices are so
What do
wide.
you
So
think?
you're
Just to
mostly
So
run.
stacked.
Yes.
Yeah.
I'm gonna
We'll
ask
do it. Yep.
Rahul and Vivian, you guys do a diagnostic angiogram. Give us, we can all collectively come up with a treatment strategy, and then we should probably wrap it up. But I think that this is a good conversation about how do you manage, GE varices, from the portal side, and what's the preferred agent, and then it's probably a good idea to wrap this up.
Yeah, so I think I agree with Saher. It just depends, what the goal is here. I think, he had varices. My preference would be to try to sclerose them. So I think we'll put like a Fogarty up and then just push STS, and then we can push, a couple 035 coils here. Again, with these you have to be a little bit careful sometimes, especially in patients with portal vein occlusion. Sometimes there's communications back towards the liver, more so in patients with splenic vein occlusion. But you do have to be careful, so when you push the foam, that you're not pushing it, that you're pushing it into where you think it is, where it's going, that's going into the systemic, into the varices and stuff. You don't push it too far. We'll do an angiogram. We'll do a couple angiograms at the end. One, we'll do an SMA just to show that the sort of natural flow is going in the right direction. I think where we've gotten burned, not so much in this patient, but in other patients who have like bad SMV occlusion, it looks good on the venogram, but then when you actually do an SMA angiogram, the flow isn't going where you think it's going, and those patients have a high likelihood to come back thrombosed. And then we'll also do, once we get the access, the splenic access out, we'll do a splenic angiogram as well, just to make sure he's not bleeding from that site. In terms of the exit from the spleen, there's a whole bunch of different ways to do it. You can do gel foam, you can do coils. We've done glue, we've done Obsidio. I think whatever works well for you, I think it works. Our plan probably here is to either use glue or Obsidio just to get it out, and then that way we can start him back on his Lovenox fairly quickly post procedure.
So
Just
let me
a
ask a,
quick
a couple of questions. One is that you said you're restarting the patient on Lovenox. I think many people would reflexively be concerned about the idea of starting somebody on anticoagulation, given how complex this procedure was with all the different accesses, splenic access, transabdominal access, etc. I was hoping that, Rahul, Vivian, Saher, you could comment on what the role is here of anticoagulation in the acute setting, and then in the immediate post-procedure setting. And then if you could talk a little bit about how both of you manage these patients in terms of planning for discharge, and in the outpatient setting, what's your longitudinal comprehensive clinical management strategy for a patient like this? I think that would be very, very well received by our viewership.
Saher, you can go. You can go first.
Yeah, I mean, I think for in the acute setting, I'm more aggressive with anticoagulation. I try to
Yeah.
start them, that night maybe, but it's something that's chronic and there's not residual clot. I try to start it the next day. I mean, there's no reason to take the risk. So that's kind of my approach in general. For embolization, the splenic axis, I usually use an MVP plug or coils and MRI coils or something that is MR compatible, and follow with gel foam. That's going to be the main thing I've been using. So if I do this and I'm comfortable with it, then I'm fine anticoagulating, something like 4 hours after. But in this case, probably the next day is fine. I usually, depending on if it's at the top of stents, if I end up extending the stents further in, the JAK2 mutation or some of these hypercoagulable patients, I would actually bring them down for a second look, and I would just take another look, measure pressures, and re-angioplasty as needed. In a case like this, probably there's no need. I'll just bring them to clinic 2 to 4 weeks after with an ultrasound, and then we'll follow up. If they have a shunt, I also like a splenorenal, that also get a CT, and then I follow them as long as they have the tips before till transplant or death. Basically, I just follow them all the way. So that's kind of mostly my algorithm.
Yeah.
Rahul, anything you want to add to that, or Vivian?
Yeah, so we protocolized it. So the way we do it is we'll leave actually a 10 French sheath in his neck post procedure while he's in our PACU. We'll check a VBG or a CBC right when we're done, and then to get a baseline, and then we'll check it again in about a couple hours once everything else is obviously out. And then if everything looks good, then we'll restart them on Lovenox. Heparin is a little bit trickier because I don't want them. We've gotten burned with the heparin when they try to give them the bolus and they sort of shoot past the PTT goal. So there, we'll try to restart the heparin without the bolus. And try to get them up pretty quickly, but the Lovenox I'm a little less worried about. In terms of switching them to an oral agent, usually there's no data for like when to switch them. I treat them like we would like a DVT, basically 2 to 4 weeks of Lovenox until their first follow-up. If everything looks good, then we sort of tell the hematologist or the hepatologist that let's switch them to a DOAC from there. But there's no data for that, obviously. And then again, we do 2 to 4 weeks follow-up. We've talked about trying to bring patients back, sort of for a second look. We've done that with the acute portal vein thromboses. We haven't really done that with the chronic patients, but glad to see at least Saher and I are sort of similar.
Yeah, and
Yeah.
As far
Rahul,
as their
the
bleeding
the
risk in terms of the immediate post-operative, I feel like
Yeah.
the splenic access is the one that's most
Yeah.
critical. So we've used all sorts of things, but I feel like the sort of definitive liquid
Yeah.
is good if it's a patient that's
Yeah.
acute and needs to be anticoagulated.
We looked at our data for transsplenic and even in gunsight tips, in patients that had, there was no difference in the patients that got TPA in terms of bleeding risk, in intraprocedural TPA for the acute portal vein thrombosis, or patients who are on blood thinner. They all sort of bled the same rates. So, it's just basically it's a comfort level at that point.
and the imaging protocol and office visit protocol, Rahul.
So for this guy, we can just get an ultrasound because we can see everything. For patients that get sort of an extended tips, the ones that go further into the splenic vein, or ones where we have to really go in deep and balloon the SMV to get everything open, we'll get a CT scan and an ultrasound at the first visit. And then after that, if everything looks good, then we'll just sort of do ultrasound follow-ups, maybe once a year or once every couple of years, CT scans, depending on what the flow and the tips looks like. But I don't want to subject these patients to CT scans every 6 months,
I agree.
Fantastic. Rahul, Vivian, thank you so much. As usual, you all make it look very, very easy. I know you've got a moderate amount of work ahead of you with the embolization, but I think we all learned a lot here, and it was a fantastic conversation about how to manage these, very, very difficult cases. Just from my own personal anecdote, I think these patients as recently as 10 years ago were considered no option patients and had to just manage with their symptoms on an expectant basis. But I think as many sites and centers of excellence are emerging across the United States, obviously Medstar being one of them, and our center in New York at Mount Sinai, I think more and more patients are finding that they have therapeutic options and are able to have significant improvements in their overall quality of life. In closing, I want to thank my dear friend and colleague Saher Sabri for joining us this morning. Saher, fantastic conversation, and your insights as always is incredibly valuable. I want to thank everybody who logged in today. I want to thank all the staff, the techs, nurses, and the anesthesia team for helping getting this case off the ground and allow us to share it with our audience. And most importantly, I want to thank BroadMed AV for their AV tech support. They always just do a fantastic professional job, and without their assistance over the last several years, we wouldn't be able to share all this fantastic content with all of you. On that note, I just want to thank everybody. Have a great day and have a great weekend, and we will see you all next month.